Hi, everyone, and welcome to another edition of What's Up, Doc. We have been getting so many questions in our Facebook group, PAD support group.org, in case you have not joined. And so we wanted to bring on an amazing vascular surgeon from the Dallas area, Marc Salhanick. He is with Complex Vein and Vascular in the Dallas area. I know he has multiple locations there, and he'll talk about that in a moment. But we have so many questions coming in. Make sure that we have Josh, our incredible YouTube producer out there, and he is gathering the questions. So if you have questions, you're watching on YouTube, go ahead and get them in comments now because we have about 30 minutes or so with Dr. Salhanick, and I want to make sure to get your questions in on this Sunday. So get those questions in now. Welcome, Dr. Salhanick. Thank you for spending your Sunday with us. We really appreciate all you're doing to save life and limb during the week and then helping us globally here with our network of patients.
Thanks so much, Kim, for having me. It's a great honor to be invited to speak to your followers here and to have an opportunity to answer these questions. It's a disease process that is very important to me personally as well as professionally, and so I have great excitement to be able to come on and help support what you guys are doing because you're doing fantastic work.
Why in the world did you decide to commit your main part of your practice to legs? You're a vascular surgeon. There's so many different areas in which to specialize. What is with the foot fetish?
Well, it's personal for me. So my experience and what brought me to vascular surgery was actually my family. So when I was training in general surgery at Parkland here in Dallas, I started to kind of understand kind of what the vascular patients were going through an experience with my dad. So was maybe about it actually had started in medical school when his diabetes and hypertension that he had a really hard time getting that under control and took his kidneys and he ended up on dialysis. And then he would tell me, he'd say, oh, well, I'm on dialysis. What's the worst could happen? And I was a medical student at the time. I was like, well, all these other things could happen. He said, that's not going to happen to me. And sure enough, it was about my second year of residency that he ended up with a toe wound on, I think it was his right leg first. And because of, I guess, the tools at the time, and to be frank, I really didn't understand much about vascular surgery. I mean, I was a second year general surgery resident. I thought I knew a lot. As I know now, I knew very little at that point in time. And long short, he ended up with a major amputation with very kind of little that maybe could have been done at the time. I still have never actually looked at his angiograms. I just kind of, trusted what the doctors had to say at that point in time. And he went from I have a toe wound to I have a below knee amputation very quickly. And then it was about 6 months later that he developed a wound on the other side, which, as I'm sure you know, and other of your doctors that have come on have said, about a quarter of the time, patients that have a below knee amputation will get a major amputation on the other limb because of the mechanical difficulties of just walking around. And so they end up stubbing their toe again. The whole process repeats itself. And it was about a year from when he had the first to the second that he became a double amputee. And when I went through that journey with him, I started to understand a lot better the fear and the anxiety and the stress and all the other things that went into what had led him to that point, let alone his disease process, but just the very human nature of, what's happening with my body? How do I prevent this? Like, what can I do? And not everybody handles that in the best way. And I love my father, but he did not handle that very well. But I started to say, I have an opportunity here to take care of patients. And like I said, it was at that point in time, my third year of residency, where at Parkland, when you're a third year, you were really in charge of running things, running the service. And I really got a very good experience with the vascular patients there and felt really called to take care of them. I shared my experience, my dad's experience with them. And though it wasn't everybody who necessarily was ready to hear that story, but there were people who were ready to hear that story. And we were able to work together and, to be frank, save some limbs because of it. And that's when I said, this is what I got to do. And like I said, I just felt called to take care of vascular patients. And at that point, I went to the program director at the time and I was like, Dr. Madral, I'd like to get in the early specialization. I want to cut a year off of general surgery and let's just get right into this. And he said, you're about a month late for that. So that's fine. I finished out all of my general surgery training and was able to get on at Southwestern for vascular and had a fantastic experience. Got to meet some really great and amazing people like Darcia, who you had mentioned. It was really a huge educator for me and kind of mentor for how to treat CLI. And I think the rest is still history that we're building, but that's what brought me here. And so it's become a
So
very
many doctors um, give up on patients very quickly. I'm sure you see it every day.
yeah,
Some just don't believe in treating below the knee because why delay the inevitable is what they say. It's not durable, so why do it? There are others to say they're just not going to take care of themselves.
yeah. They
So I'm
blame
just
the
not going to
patient.
waste my time, right? So I'm sure your dad's story has played a role in the extent to which you go to try and save a limb. What is the extent to which you go to save a limb? I mean, when an amputation is on the line and you say, why not try? But what does that mean to you?
Yeah. So it's balance. And I am always going to at least try for a patient. Now, like I said, it's a balance because someone comes in and their foot is black all the way up to the ankle. That's kind of the horse is out of the barn at that point in time. But that's very, very few patients. I would say we maybe see one or two patients like that in the entire year. The vast majority are patients like you had described that their doctors had said, like you said, it's not durable. Why do I actually have had one person tell me to stop doing interventions below the knee because they don't work. And I said, why don't you even look? And they said, it's not even worth my time. And they just do a major amputation. Yeah. And so I was floored by that because, like my dad, I mean, he shows up with a great toe wound. I mean, it's not great. He's probably, if you had seen his toe, you would have seen that that toe is not long for this earth. But it's a big difference between a minor amputation of a toe wound or even a TMA and a ballooning amputation. And there's just so many patients out there that don't have this opportunity to come talk to someone that, to be frank, has the skills now, and through some really amazing devices that we have now. I think you've done some work with reflow. We've used spur now. I think we've done our 10th case since May when it first came out. We're seeing just amazing results with those. And
It's a new
changing.
retractable stent. I'm sure,
Yeah,
the folks here have heard a little bit about it through our network, but
yeah,
the reflow has a spur. Considered a retractable stent, and it's for below the knee
correct.
issues that you may have.
And it's changing that durability comment. And so you ask, like, how far am I willing to go? I'm willing to go all the way down to the digital artery if I need to. We're recannulizing not just tibial arteries but DPs. We're going into the foot, we're going through pedal arches. We're going ham on these because a lot of the time all you need to do is get that situational perfusion. And what I used to tell patients was that it might only last for about 3 months, but if your wound can heal, the body's pretty amazing. And if we can heal this wound, your body can kind of take care of the daily maintenance of that. And then we flip over into what do we do from there? How do we keep from getting another wound? And that's the less exciting stuff, but the vitally important stuff about protecting those feet and talking about good footwear and having someone to monitor your feet, working with podiatry very closely. We strongly value our partnerships with not just podiatry, but wound care, the prosthetics people that we use for AFOs, for people that have, foot drop and other mechanical issues that put their feet at risk for getting minor injuries, and just building up a whole network, an environment for people to have their feet protected that can keep that wound from coming back. And we have a lot of success stories of we got the wound healed and saved their leg, and through these other interventions we've kept them from even having another wound.
Want to remind everyone to go ahead and put your questions in chat or raise your hand. I see Heinz has already raised his hand. We have a great live studio audience here on YouTube. Make sure you do let us know if you do have a question. Raise your hand, put your question in chat. We will get to you. Your face will not be shown on the screen. It will just be your voice. So don't worry, don't worry about shyness. We'll get you in. You can write it in chat, or you can just go ahead and voice it and speak yourself to Dr. Salhanick in just a moment. For those that are on YouTube, make sure you like the video, subscribe to our channel because we have great content like this all the time. And don't forget to click the little notification button because you can subscribe, but get notified when we have great doctors such as Dr. Salhanick on who can answer questions live, such as we are doing right now. But before we go into our first question, I want you to let everyone who's tuning in right now know that they don't need to just settle for amputation. If their life is on the line, that's a whole other story. We had
Different.
Dr. Sarah Rose, a podiatrist from Mass General, come on, and she had a patient that refused to consent to amputation, really thinking, hey, let's wait, let's ride this out. She said, no, you don't understand. You are septic. You are going to die.
Yep.
And she literally waited. I mean, she said it was a slow process. Every day she was going in with spiritual leaders, everything to try and get the family to like act. You have kids. You're going to die. You need to get this leg gone. It's your life or your limb. And that is where you really don't want to wait ever to get that amputation. Trust your doctor and do it. But what would you say to most patients who are out there where you shared the story of a doctor who said, why bother? I'm not treating below the knee. You can't. Well, they don't even tell the patient that it's because of blockages below the knee. They'll tell patients, well, you need an amputation because you have an infection. You need an amputation because you have diabetes. You have an amputation because you have too many blockages. And we even have some that tell the patient, oh, your veins are blocked. No, it's not your veins, it's your arteries. So they don't even know what to doctor Google.
Mm-hmm.
And so they'll even, this is my favorite one. Sorry, Dr. Salhanick,
Oh,
but with
please.
Deion Sanders, famous Coach Prime, you need an amputation because you're clotting, you have too many clots. Not even telling the patient that, you know what, you have a disease called peripheral artery disease. Yes, it's exacerbated by your hypercoagulability, but it's called peripheral artery disease. Atherosclerosis plus clot still equals PAD.
Yeah.
And if he knew that it was PAD, he could look up that there are other options versus amputation.
Right. 100%. And what I tell patients all the time is, in my mind, there's two reasons to do a major amputation. We cannot get your pain under control. And in those cases, I mean, we do try. But like I said, if we cannot, either through endovascular surgery or open vascular surgery, relieve the pain from that ischemia, that is a reason to do that major amputation. Or your life is threatened by that infection. It is exceedingly small, the number of patients that we have that have those issues. And like I said, it's maybe 2 or 3 in the year. The thing that I'm encouraged to hear that you were working with a podiatrist that was willing to go out there and say, I really think your life is threatened. You need to do this. We've had interactions, and there are podiatrists, unfortunately, in this city that, there's this question of how much is too much, because like I said, it's a balance. And I am willing to go as hard as I can for patients. But I can give you an example here. There was a patient that I saw in the hospital that was septic. And what we mean by that is that they have a source of infection and they have an elevation in their white count. Okay. So this is important to understand, because just because you're septic doesn't mean that you need to have a major amputation. Really important, because maybe all you need to have is a podiatrist that's willing to come in, like at one of the other hospitals that we were working with today. Podiatrist came in, did a amputation of the toe to get source control and clear out that infection. That patient is getting better. So yes, they were septic, but they're not in shock. This patient that I'm talking about was in shock. What does that mean? That means that their body is systemically suffering from this infection, is trying to fight this infection, and is losing. So that patient that's in shock, that's a situation that your life is at risk, and you need to have the source of that infection, which is unfortunately sometimes the entire foot, removed. And this patient was in shock. They were getting blood pressure supporting medications because they were not able to keep their blood pressure high enough because of the shock. That is a really severe scenario. Their life is threatened. And I'm telling them, you need to have this amputation. And this patient said, my podiatrist is on the phone with me and is telling me that you're wrong. You don't know what you're talking about, and that I need to be transferred to them so that they can save my leg. I'm like, okay. And so, I'm not going to ever, um, try and strong arm a patient into anything. So we transferred that patient. I hope that they did well. I don't know what happened with them, but it does worry me that, I mean, there are some times where we do need to say, this is a time where we really need to do it. There are a lot of providers that are unfortunately way too quick on the draw with amputation, as you've talked about. But I think you've highlighted really well the very small number, but very serious reasons to go ahead with that amputation.
There's a lot that goes into it, and it's so tough for a patient to make that call, if, especially if they're stuck in the hospital. They feel like they're jailed in. They feel like they have no choice. They feel intimidated by their
And
doctor.
sometimes
They
they
don't
are.
know.
I mean, it's more than a feeling. Like they are being
Yeah,
strong-armed and bullied into these, because I've seen these scenarios, and
I'm
I mean,
glad you said it, not me, but
yeah,
it's
they're being
true.
bullied.
It is what happens.
And they're being blamed for their disease process too, because that's the other thing, is that I've seen, not podiatrists, I've seen vascular surgeons walk in and say, well, if you just controlled your diabetes better, or, if you had just stopped smoking. And I'm just like, that is just not, that is, blaming patients for their disease process is never the answer, as a doctor, period. And then you get into the whole, like we had said, there's guilt and shame and all these horrible feelings that feed back into why patients end up in these situations. And it just makes all of that so much worse. And at the end of the day, it's not good for them for limb salvage. It's not good for them
Yeah,
just physically and emotionally. And what I would have to say is, I mean, it sounds awful, but you have to get that second opinion. You have to talk to
you have
someone
to.
who is willing to talk to you. And I mean, I have had situations where I myself have been talking with a patient and said, listen, you're in a situation where I don't see a revascularization option. I'm going to ask for a second opinion myself. And we had brought up Dr. Sia. I have sent patients to him and said, hey, Mike, I don't know what other options there are for this patient. I can't foresee any. Can you foresee any? And I think that's really important. We always had a thought, so coming through general surgery and going through trauma, we would have patients come in that would have these things called mangled extremities. Imagine that someone's on a motorcycle in a motorcycle crash going 90 miles an hour and has a very serious traumatic injury that I don't necessarily need to describe all the gory details of, but they have a limb that is no longer going to be functional for them. And to be frank, they probably just need to have an amputation. We had a protocol that no one service could make that decision. It had to be a number of services coming in and saying, from my standpoint, from a neurologic standpoint, this is not recoverable. From a vascular standpoint, this is not recoverable. From a soft tissue standpoint, this is not recoverable. And you would have multiple teams of doctors coming in to evaluate these patients. I think that that's fair. And I try and move forward in my practice with that as well, not necessarily calling other types of doctors, but calling in other vascular surgeons and having them give their opinion as well. I think it's important.
Yeah, and I think that it's important for patients to know, because um, our friend Marcia, that is on here right now in the live studio audience, one of many, she was just on the phone with me before this, telling me about a patient that she had brought to me a while ago. It was actually a friend of hers that said, "Hey, she's on deck for amputation." Actually, now another amputation. But the patient just kept agreeing to it because she liked the doctor, trusted the doctor because they had the title and the white coat, and just didn't see any other option. And she's like, no, you need to call the Global P.A.D. Association, the Leg Saver Hotline. There are doctors, they can get you transferred to a larger tertiary center where there may be options, but they just sit there because it seems like a lot. It is intimidating. You may like your doctor. They may be the most charming person and care so much. They may cry with you as you're sitting there in bed, but this poor woman lost her life because she liked her doctor and didn't want to upset him.
Yeah. It's
And that
it's
makes me so sad.
yeah. And the other part of that, the other component that I would put in there is, again, that, you know, that asking for a second opinion doesn't mean that you don't trust your doctor. You can trust your doctor. You trust that they're giving you the best advice that they can, and they are presenting you with the best option that they have. A second opinion is not a failure on that doctor's part. And I've had to talk with junior doctors about this, and the residents about this. Getting second opinions is not a failure on your part. It is a what am I trying to say? It's a honest want and need to make sure that there aren't any other alternatives, you know? And
So recognition and an
yeah,
acknowledgement that innovation is moving at the speed of light. Medicine is a practice, and innovation rolls out different across different,
mm,
even different cath labs within one
yeah,
facility versus another facility. You've even had it in your facility. Not every doctor has the retractable stent known as spur by reflow.
mhm.
You have it, but maybe the most doctors in your area, I
Most
know that
doctors don't.
one of your mentors,
They-
Dr. CS, has it, but most doctors do not have it. So they may not be able to treat the vessel below the knee.
Yeah,
And
we're
that
the
may be
only HCA
legit that,
facility that has it, actually.
right? They don't have the option. So
All
that's,
of HCA, we're the only HCA facility that actually has it.
yeah. And I think that it's really important. You also have patients. There's a technology that I heard good things about you from as well, Holly, from Endologics, the
Yeah.
minimally invasive bypass. There
Yeah.
are a lot of diabetic patients. They're not candidates for a surgical bypass. So they say there's nothing we could do, but there might be one or two facilities as they slowly roll this out that might have that as an option for you.
Absolutely. And I think the other thing that it's hard for people to think of and realize, and I mean, and the doctors are also guilty of this. I thank my sainted wife and her family for helping keep me grounded and realize that I do not have all the answers. And that just because I have the MD does not necessarily make me the expert on everything all the time. Uh, but other doctors, I mean, there is an ego aspect of it as well. And I've seen, unfortunately, doctors say that, you know, this is what it has to be and there's no other option. But
Yeah.
what they're really saying is, I have no other option. And it's very hard for them to say somebody else might have another option. And so that's a hard thing for patients to navigate as well. Again, you know, there's the whole relationship. I trust my doctor. I think that they're doing the right thing for me. Because think about it this way, Kim, you know, at that point in time, you've been trusting that person all the way up to this point.
Yeah.
I mean, it's kind of like, you know, you have a relationship, you know, with a significant other, and then suddenly you realize it's like, well, they may not have really had all the answers, or what they said maybe not be 100%. You know, have I been lying to myself? Have I been lied to? You know, that feeling as well of like, you know, how could I have been so blind to not see this? And you know, there's a lot that goes into that, that it just makes it hard for people to say, you know what, I'd just like to get another opinion about it. So it's hard. I know that, you know, I've seen with other interviews and, you know, with the work that you do with the Global P.A.D. Association, you're constantly trying to encourage people to get that second opinion. But, you know, for everybody in the audience and that's hearing this, simple, not easy. It is a hard thing emotionally sometimes to negotiate for a lot of different reasons. That said, you know, I have yet to regret being involved in a second opinion or asking for a second opinion myself.
Yeah.
More information has always been better, and it makes people feel like, okay, we're really in the game together. We're trying to find the best answer for you, and trying to do the best thing for you.
Yep. Okay, we're getting to questions. I could talk to you all day. We're going to have you back. I think we
Okay.
need to have you back on the mental health side of things,
Yeah.
because maybe we'll have you during our weekly hangout on a Wednesday where people are sharing, the patients are sharing the mental trauma of this disease, and have you help facilitate and share your experience with your dad. That would be amazing.
Thank you.
Especially as a family member in that situation, we have a lot of questions about that. But Heinz, you've been so patient. We're going to go to Heinz, and then we have, I think, Allison, who's putting a question on YouTube. Again, put your questions in there in the chat on YouTube, or in the chat here, or on Facebook, and we'll get to them. Go ahead, Heinz. Thank you.
Hey, good afternoon. Thanks for spending your Sunday with us, Doctor. This is a general question, but it affects me also. When you get stents, they put you on Plavix. Is that a lifelong thing? And
Heinz coming off the top ropes with the hard questions.
I always do that.
That's good.
He does. Oh, wait, he
love
could
it.
go on forever. He could ask better questions than I can.
No,
Yeah.
so
Great.
I'm sorry to interrupt you. I'm just excited about the question. Is there any other follow-up or anything else, or
Well,
would you like me to start answering?
At a point when your stents fail, and although I'm still walking without stopping, I do get claudication. Is the Plavix doing anything? And I'm also on blood thinners. But again, it's kind of a general question for everybody.
Yeah. Thank you very much for that question. I think that's very important. It's very timely because let's just break down like what's the evidence for this. And the bottom line is that there's not great evidence for it. And I think that just comes from it's very hard to randomize these things. We can look to the most recent trial, maybe Voyager P.A.D., where they were looking at adding Xarelto or one of the other direct oral direct thrombin inhibitors or oral anticoagulants. And the problem that study was really fascinating in that it showed patients that it would have interventions, stents, bypasses would have longer patency or how long they were open because of adding that medication. But the thing was that when they did that study, they said, okay, well, let's put an antiplatelet in there as well. But they weren't consistent with, is that aspirin or is it Plavix? And so they had some people on aspirin, some people on Plavix. Having an antiplatelet with it was helpful. But the point is that there are a lot of studies that are like that haven't really tried to just narrow it down to just like what is the benefit with just the Plavix alone. I think that there's a registry that Dr. Banerjee runs called, I think it's called the Excel registry. And he looks long term and he sees that there is a benefit to Plavix, but it's pretty short. And that's consistent with what we see in other vascular beds. An uncovered coronary stent, Plavix is indicated for 6 months. That tends to be about the same for these vascular stents. But the problem that we have versus the coronary is that this is a very different vascular bed. This is a vascular bed that has consistent high distal pressure versus the coronaries, which have no distal pressure, so they have continuous flow. There's actually no drop in the amount of flow. If you have a drop in flow in your coronary arteries, you have a heart attack, so that's bad. In this case, where you do have that consistent back pressure, which is actually what generates the pulse, there's some amount of slowing down or even stopping and reversal of flow in that stent. So having something to keep platelets in particular from aggregating onto those stents is probably important. We see this a lot in patients that have aneurysms, and then they have like a large aneurysm, and we'll repair that and we'll do a really great job. The way you know you did a really great job of sealing that aneurysm for a big aneurysm is that their platelets actually will just plummet. And the reason being is that you have trapped blood in the aneurysm, but you also allowed blood to reline that those stents. Even with Plavix, even without Plavix, it seems to do that. So, I think the answer is that we don't know. We don't really know how long it should be, and that's why you see so much inconsistency between different providers on how and when. The approach that I take is that for anything from the SFA down, I'm generally going to recommend 3 months of Plavix. If we put a stent in, it's a bare metal stent, I'm generally going to recommend 6 months of Plavix, with the understanding that if, like in your situation, it goes down, there's no purpose. I got called about the situation about a week ago on a patient that had a GI bleed and occluded SFA stents. And they were like, can we stop the Plavix? I was like, yes, please do not give them Plavix. They're going to bleed. They're already bleeding. So if the stent is still open, I think it's really hotly debated. I think that you could start a big fight at VAM or Sky or Viva by being like,
conferences.
no Plavix after stenting, and then someone's going to like get up and just start throwing punches. So, in your particular situation, I don't see a benefit to, what you have going on with those stents right now. But I think it has to be individualized to each patient. We have a general set of guidelines, and then I think that we have to look at the patient in front of us and really make decisions based on that patient.
And we also have Dr. Naida Dua just did a study, I don't know, in the last couple of years that showed that Plavix actually isn't effective in quite a few people, and especially it isn't effective in some patients with a certain statin. And patients should have a Plavix sensitivity test if things are not working
Yeah.
properly.
It is interesting about that because tell you another quick story. I had a patient that we did TCAR, which is a transcarotid stent, and that went really great. The patient was about a year out from that stent. Was not sure that they were really a Plavix responder. Had taken a platelet assay and said that they were not a Plavix responder. That patient was taken off Plavix, and also because of some other reasons was taken off of their statin. So this is the left side that we had put the stent in. We were watching the right side, which was a very mild amount of narrowing, 1 to 59 or 49%, which is very, very small. The chances of that progressing to something really severe like 70 to 99% or even having a stroke is less than 1% in 5 years. So shouldn't have problems. Within 3 months of stopping those medications, had a stroke on that right side. And that right side had progressed to, it was like 80% stenotic. And I was like, should have been, not a big deal being off the Plavix, wasn't really doing anything. I think that the jury is still kind of out on how do we really understand these. And I mean, like you're touching on a very exciting topic of mine that I hold a lot of things near and dear to my heart. One of them is platelet aggregation assays and like how blood clotting works. And I've done a lot of work on kind of different things that form blood clots and, how we can get platelets to aggregate or not aggregate because of that. And I think
we're going to have him back for a whole other segment. I mean, we could get about 20 to 30 questions on that.
Yeah.
I mean, the number one question we get is what's the difference between an antiplatelet and an anticoagulant therapy? And Dr.
Yes.
Naida Dua explained it, but people still have questions where she explained it as the antiplatelet prevents the Legos from connecting, and then the anticoagulant prevents, is like the glue, the fibrin, holds them together.
Interesting.
But I'm not sure. It still is not quite as clear to me as I think
Yeah,
that.
because I would actually flip that around because I think of Thramin more as like the Legos having the little. I've actually described that as Thramin. When it gets activated, the bumps kind of pop up, and now you can stick more Legos onto it. And when Thramin is snipped or deactivated or has been turned into chronic thrombus, all those little bumps get sheared. Platelets are an interesting thing because it would be like if you're making Legos and then suddenly you have like a little thing that allows you to put like 300 times the Legos in the span of the same amount of time, and just accelerate what you're doing. It's fascinating. Hematology is fascinating.
Yeah. And I want to get to Allison's question, but then we probably are going to go back to a little bit of bloods here, but she's
Good.
watching very patiently on YouTube and had put it on this question a while ago. Again, if you have questions, go ahead and get them on. I'm so sorry, not sure how much time you have, but we do have quite a few questions that have come in.
My wife
So
is the same. She's
Allison,
holding it down at home.
good. Yay.
Thank you, Natalie.
So tell her thank you.
Oh,
Allison has P.A.D. She's had it for about 2 years. She's feeling it in her feet, and it's really bothering her. As you know, a lot of doctors say, we're not going to open up those arteries in the feet, even if that's your problem, until you have a wound that's not going to heal, or you have rest pain, those Charlie horses that are waking you up at night. But there are a lot of patients that are suffering with cramping in their feet, burning, tingling, really severe uncomfortableness.
First of all, Allison, I'm so sorry that you're going through that. I mean, like it's something that you have to deal with every day, and I'm sure you've seen a bunch of doctors and you've gotten a bunch of different opinions, and it all becomes very confusing. So, I think that the advice that Kim was giving just on the face of it, is a good general starting point. And I do tell most of my claudication patients that. In fact, not most, I tell all of them that. As awful as this is not a limb threat. And the reason why, and I want to make a difference, you know, just because it isn't going to kill you, it doesn't mean it's not bad and that we should be like, oh yeah, no, you're fine. No. But we need to make sure that we're not putting your limbs at risk. And as good as I think that I am at surgery and as good as I think my skills are, you know, there are things that can occur downstream of doing interventions that can really put your limbs at risk. And I unfortunately, we see a lot of patients that come from other vascular specialists that have done interventions for these kinds of things. And to a man, they're all like, I wish I'd never had it done, because they were just worse after it. So as awful as this is, we can make it worse. And I think that we have to, as vascular specialists, have to have a healthy respect for that. And so that's where the disease process is really important. And for claudication, your risk of major amputation is less than 1% per year. Okay, so that's the limb salvage aspect of it. Let's talk about this pain. Just because, you know, it's not going to take your legs doesn't mean we should ignore it. We should try and run this down. There are a lot of reasons why you can also have pains from this. Chronic injury to the foot. This is again why we work with podiatrists, getting MRIs and evaluating the ligaments in the foot and other potential for like chronic fractures. We've seen some of those. Venous dysfunction. That is not typically a pain in the foot type problem, but sometimes we can find some perforator veins or other varicose veins or dysfunctional superficial veins that are adding extra fluid. Even though you're not seeing a lot of swelling, you're feeling the pain. And then nerve dysfunction. This is a really difficult one. And this is why I have respect for neurologists, but do not want to be one, because it's so nice being a vascular surgeon where it's like, okay, you have a pulse in your foot. I know that there is no disruption, significant disruption of blood flow from your heart all the way down to the area I can feel the pulse. When it comes to neurology, you could have an injury to a nerve at any point along that nerve, starting from the brain, through the spine, through the peripheral nerve, down to the foot. So there are a number of nerve entrapment syndromes that can occur. There are a lot of spinal stenoses that can occur, other neurologic deficits. And so this is, I think, why we're like top referred to spine surgery from our practice, because we do tend to find a lot of spinal issues. And those things are really attributed to the issue. I'll give you another patient example. There was a patient that came and saw me about a year and a half ago, maybe 2 years ago. Terrible, intractable pain. Actually was sent by this patient's spine surgeon saying, hey, I think that this is a peripheral artery disease. And I performed a lower extremity ultrasound. It was very clear that the anterior tibial artery, which is the artery that goes on the outside of the foot, or sorry, outside of the leg, and then comes down and runs onto the top of the foot. This artery was definitely damaged, or at least appeared to be damaged in comparison to the other side and comparison to the artery that runs behind the ankle, or the posterior tibial artery. And I had to tell that patient, I said, yes, you have P.A.D, but I don't think that's causing these terrible pains that you're having. And I know that the spine surgeon doesn't think that that is as significant as he thinks it should be, but I think it is. I think he may be wrong in that standpoint. And unfortunately, we went back and forth on this with this patient for a couple months. And I did say, like, hey, you know what? I will do an angiogram just to kind of show you that there's not anything significant there. The artery was very small, and it was clear that there was not a P.A.D necessarily. Let me phrase that. There was not a focal lesion causing that problem. It was the whole artery just was diffusely damaged by time and living life. I think the patient also had some diabetes involved, and their diabetes was pretty well controlled. But the point is that arteries get damaged. That's kind of comes with the territory. And I can tell you some other stories about patients that shouldn't have any problems but did. But the point is that actually Deion Sanders is a great example. You wouldn't think that a healthy, vibrant athlete such as him would have P.A.D, and yet he does. genetics can happen. But the point is that I told that patient, I said, intervention is really not the answer here. I really do think you need to have your spine fixed. Went and had their spine surgery that night, gone. And so I was really glad, and I came and talked to the family afterwards. I was like, really glad that we found the cause of this. But I could also see, and I told the patient's daughter that other vascular providers would have tried to do something on that AT. And I don't think that was the answer. I'm glad that we didn't. And I'm glad that we had a chance to take care of that patient so we could get them to someone who could help them. And I think that may be what we should look for. I mean, I don't know if you've looked for other things going on, but I think those are a number of things that we could look at.
I think that that's a really great point, because we have patients that will post their ultrasounds in the group or their CT angiograms in the group because they haven't been able to get the results first. And they'll go to the doctor. The doctor says, well, you have these blockages, they don't match your symptoms. And so no, we're not going to treat. And I think that that's a really important point for people, that just because something is blocked, it doesn't mean that it's causing your symptoms that are most bothering you.
100%.
And so, you don't just treat for the sake of treating it, because as some have said, it can lead to amputation much sooner than before. So this is a disease that is so important to make sure the symptoms match, right? And
Absolutely.
that you do everything you can to mitigate those risk factors. When it comes to these foot issues, the first thing that we see is you've got to get that diabetes under control, get it under 6 if you can, and then stop smoking if you can, so that the arteries stop spasming. We see that all the time. And then number 3, which I find really interesting, is a vascular surgeon and a podiatrist, Hope Vascular, Brian Lepeau and Miguel Montero Baker, are proponents of Metamix, which is a prescription B vitamin, which has significantly helped so many patients out there who have this neuropathic pain. So there are these options.
I'm gonna write this down. I'm learning things today. You said Metamix?
Metamix. Oh, it's literally, it's a B vitamin on steroids. The only problem
Awesome.
is that it's not covered by most insurance. And in order to get the good deal on it, so it's not $200 a month, there is a place out of Florida that they send patients. I think it's called branddirecthealth.com or Brand Health Direct. And so if you write a 3-month prescription, they can get it for like $60 for the 3 months or something ridiculous. So much less than $200 a month. But for example, with my dad, he was able to get his feet back, within just a few months of using it. And he's like, and he also has the MTHFR mutation. So it brought his homocysteine levels down significantly, and his B vitamins up, and everything seems to be much better after being on it. But I thought it was interesting, as I hadn't heard much about that. But anyway, the other thing that we're hearing is a lot of the patients with their feet going to the podiatrist, and if they have plantar fasciitis, there's a brand new technique called artery embolization. And there are some doctors that will do that as well, and just go in and zap those, embolize those abnormal arteries or collaterals to get the pain out of the foot so they can get out and walk. So
I have a little anxiety about anyone saying
I
the word
know, me too.
embolization with the Global P.A.D. Association logo right behind it. Like, I have a lot of anxiety about that. But I think
Me
your point is
too.
really important, that like,
Yep. You got
intervention
to be
is,
careful.
yeah. And I, especially with claudicants, I always put that very, very, very last, because what I also tell patients is that, the body is a lot smarter than we are. And the body is going to be able to find ways around this. So let's try and help the body as much as we can. So that's where controlling the diabetes is effective, because your body's trying to make bypasses around these blockages. And I have seen, it is amazing to me. I have patients in my practice, their aorta, the main blood vessel in their body, totally gone, out, toast, not coming back. Needs to have big time surgery, cut the belly open, do big bypass to both of the groins and the main artery. And those patients, they've found ways around it. And those patients have said, I've been doing okay. We watched a couple of them for like a few years. I have one actually that I've been watching for almost 5 years now. And they say, yeah, the claudication is not great, but I'm doing okay. And that's because their bodies found ways around it, but they stopped smoking. And they got their diabetes under control, which has allowed those bypasses to stay open. The ability of nicotine to cause vasoconstriction is not really well talked about, but it is very, very strong. There's actually a whole disease process about that called Berger's disease, which literally the treatment is you stop smoking, and literally like that day it's healed, it's done.
We had a patient over in the UK. They said she had critical limb ischemia. They wanted to do an aortobifemoral bypass on this patient. And we were like, I think you need a second opinion. This seems just very odd. And she hadn't quit smoking. So we got her to a different doctor, and he was like, just quit smoking. Within days, she quit smoking. Her foot was back to normal. Toe was healing.
Yeah, it is very amazing. And that's why, again, we started out the conversation with, what is your limb threat here? Your limb threat is very low. So that means that we have the opportunities to take the time we need to do these other interventions. As I was talking with you about, Kim, when we were first talking about this, when you have a wound, it's game on. We are hardcore, everything we need to do to get that wound healed, because the doctor books all say your risk of having a major amputation goes up to like 70 to 80%. No wound, less than 1%. Wound, 70 to 80%. Now you see again why we talk about, it's not sexy, but the importance of keeping your feet protected, not stubbing your toe. The day of open-toed shoes unfortunately have gone. The pretty lady shoes, they're not great for those. You may have to give those up as well. But those are lifestyle modifications that, if we can be successful, they may keep you from ever having a procedure. You never have to take that risk.
We have Lorna that has a question. Lorna, go ahead and unmute and ask Dr. Salhanick your question.
Hi. So I have PAD and CVI, and I'm being told that the superficial veins in both legs the valves are not closing. I'm about 2 years out from surgery so that it's covered. I'm in Canada, so covered through OHIP. Extreme pain, cramping sometimes between the PAD and the CVI. I'm awake every hour during the night. During the day, unable to do a lot of walking. On top of that, I had a bypass last year because I had stents, and then one failed. Bypass 3 months later, fem to fem graft. And since then, I've had nothing but problems. It got infected. I was on IV antibiotics for 6 weeks, developed ascites after that, diabetes after that, and now CVI. So extreme pain. When they did the bypass, for whatever reason, the surgeon did not include the iliac on my left side, which was the one where the stent failed. So there's nothing there other than my surgeon is telling me to walk to build collaterals, which I'm finding very hard to do. What can I do for pain in the meantime, between now and those 2 years? Because I know that the recommendations for pain for PAD and the recommendations for pain for CVI kind of contradict each other, right? Like the compression stockings, the elevating, the whole bit.
So, Dr. Salhanick, am I hearing this correctly? So they did a fem-fem bypass without any inflow? Or did I hear that wrong?
So I think that, so first off, Lorna, I'm so sorry. That's awful. And I can't imagine the pain that you're in, having both those disease processes going on. It does sound like they had attempted to open up your iliac system on, and can you tell us which is your bad leg?
Okay, so both legs. I have probably moderate PAD now, still in both legs. I was told that I have tiny arteries and veins. So the original was a stents in my femoral, my iliac, and my aorta, abdominal aorta. They weren't even sure how I was walking still. They were that blocked. So yeah, then the left iliac, common iliac, failed. Blood clot, collapsed, whatever. And when the surgeon went in through emergency surgery, they completely left out the left iliac, and everything's basically running off my aorta, my right iliac,
Yeah.
and over.
Yeah, so that's what it sounds like. So we would say that your right side is your donor side, and that's
Yes.
bypassing to the left side. It sounds like you had what's called CRAB, which is I forget how that acronym runs, but there's some people that will do these kind of EVAR type repairs for patients to do essentially like an they'll call it like a endo AFB. That's really tough because that's a lot of stents that take out a lot of collateral. So, I'm sorry that your surgeons are like, oh, you need to, walk so you make collaterals. It's like, well, they kind of took out a lot of the branches that we use. And this is again why, doing interventions, we have the best of intentions, we have the best of skills, but maybe not the best of technology yet for some things, because no leave behind surgery is a big thing, because we don't want stents to sit there and block up these little holes that could be used for creating bypasses and things like that. But your body's bypasses, these collaterals that you've heard about. And so having extensive stenting throughout your aorta-iliac system really puts a hamper on that. And I'm not sure how open your pelvic arterial system is. If it's not open, that's going to be really hard as well. Going back to your question about kind of what do you do when you have PAD? And so for everybody else on the call, she's talking about chronic venous insufficiency. Some people will say CVI. They'll say that they have varicose veins, or they have veins that are dysfunctional or something like that. It's really hard to balance that. I would generally discourage patients from doing compression because, and I would strongly disagree with whoever told you had moderate PAD. You have pretty severe PAD. You don't have inline flow. Kind of coming back to the bypass. Personally, I do not like fem-fem bypasses, but I recognize that they are important for kind of a bailout situation. Unfortunately, there's some people that is a go-to for them. Just the mechanics of that. What ends up happening, I don't know if y'all can see my screen, but the blood comes down and then it has to go back up and over and then back down. I don't do too good on physics, but that just don't make no sense. And so what I would prefer is an aorta bifem, where you actually go in there and you reconstruct the normal blood flow that should be going from the aorta down. This is called inline flow. So another way to think about it, and sometimes we talk about it in the doctor books, is that bypass, that fem-fem bypass, is what we would also call an extra anatomic bypass, meaning that it's not necessarily the way that your blood normally flows. So if you had a wound, I would not recommend a fem-fem, because that is not going to give you the pressure head that you need to maintain the blood flow. So again, coming back to why you make the decisions that you make, I think that you really have to tell patients why you're doing what you're doing, because you have lots of options, and we really have to tailor them to your current experience. So my biggest thought is that maybe this is probably still just an arterial problem. I don't think your venous insufficiency is causing you to be in pain all the time like that. Usually venous insufficiency is going to be it hurts at the end of the day, gets better when you put your legs up. How far can you walk?
I have a problem, I don't know, maybe 200 feet if I'm lucky, without having severe pain going down the back of my butt, and almost like sciatica pain would have been. I was misdiagnosed with sciatica, but also, pardon?
But that also may be, that might actually be the nail on the head there, because this is something that I saw a lot actually when I was training at the VA, and we would have these patients that had really bad arterial disease, and we would do intervention on intervention. I saw one patient that had like 6 interventions, and they had a strong pulse in their foot, terrible symptoms, hurt all the time, no relief, was getting worse, and it was their back.
Okay.
It was neurologic. And so that's where I'm saying you may not be off the mark on that sciatica, and something may be compressing it.
Okay. So I know when they did do the fem to fem, they did damage a nerve in my left thigh or my right thigh.
Mm.
So I have severe nerve pain from that as well. And I'm on gabapentin and Lyrica both.
Can I ask you a clarifying question about that?
Sure.
Most of the time, because I've seen that, unfortunately, we do have some patients, even in my practice, that they have that kind of nerve pain. That generally is a branch of the genital femoral nerve that goes on the inside of the thigh. Is that where your
Mm-hmm.
pain is?
No, it's actually down towards my knee as well. Like
Mm.
so much so that if something touches it, I jump because it hurts. I still get, I had the fem to fem last, it was a year ago in March.
Yeah.
And I still get almost like nerve shocks where my leg will kind of jump at times because of it.
Can you, another clarifying question? Can you describe how was your initial presentation to the hospital when they found out that this left iliac stent was occluded?
I went in by ambulance because I could no longer walk. It felt like my foot, my left foot had just ballooned. I couldn't walk anymore. I was in excruciating pain. They actually, at the time, the resident that was there as well, working under the surgeon, said they might have to amputate below the knee because they weren't sure. He said because they weren't sure of the damage, if there was any damage done below the knee because of the lack of blood flow.
Oh gosh, I'm so sorry. You're in a tough spot. So what we've been talking about kind of this whole time is this chronic critical limb threatening ischemia.
Yeah.
But it's the chronicity that is important because it's an injury, but it's an injury that your body can kind of generally get better from, or it can improve a little bit, get a little bit worse, improve a little bit, get a little bit worse. It doesn't necessarily threaten your limb immediately. You suffered from acute critical limb ischemia, and that is a whole different ballgame. This is a scenario where you have blood flow and abruptly, suddenly, it's all gone. Then what we're talking about is we're talking about progressive damage. It's very similar to like having a heart attack. Okay, you only have a certain amount of time when that artery gets blocked before you start having irrevocable damage to the heart. This is why the door to balloon time you may have heard of is so important. When it comes to lower extremities, we actually have a little bit more wiggle room in that. The general thinking is about 6 hours. But once you start to get past that, then you start to get some really significant damage to the surrounding muscles, nerves, other things within your leg. But the key here is nerves. How do we know that you have acute limb ischemia? It actually has to do with your exam. I got contacted by a colleague down in the valley about a patient actually on Friday that was having some issues, and this is a new doctor and was just like, hey, kind of walk me through what I should be doing here. And I was like, first thing you do is you go to that patient bedside and you see, do they have foot drop? Do they have sensation in their foot? If they are not able to pull their foot up or they don't have sensation, that is a severely threatened limb that needs to get fixed now because they're having severe nerve damage because of the low blood flow. And by
Yeah.
proxy, everything else is being damaged. The unfortunate thing with this is that that nerve damage is irrevocable. And while the foot may come back in terms of being able to move, that nerve damage sticks with you. And I'm so sorry that you're suffering from that. I've had patients that when I was in training, they had accumulated nerve damage like this, and we did everything that we could, and it didn't matter what we did. They were just in excruciating pain like yourself. And so there are scenarios where we come back to why would you do a major amputation? We don't have good nerve treatments. And if you've taken care of the arteries, I mean, you can do vein ablations, but I don't think it's going to do much for you. But if you've done those things and it's really just the nerves, and you can actually check with a EMG, an electromyogram, which is not a fun experience, but I think it would be helpful. And you can diagnose that neuropathy, that peripheral neuropathy, that nerve damage of your peripheral nerves from your ischemia, which is called an ischemic neuropathy, then that may be your answer right there.
And
So-
we do, when we have situations like that, we also, there are some interventional radiologists that do have some additional pain management options that may be available. And so we always suggest, if you can, create a whole team around you. And I love that Dr. Salhanick talked in the beginning, about, there are different people to check with the podiatrist, check with the neurologist, check with the IR, check pain management
Whole
team, whomever
environment.
they might be. Right.
Right.
And double check, because we just had a Dr. Ankur Thapar, who is the global luminary of the year for our award series. And he was saying that when people have a DVA, he actually brings in a team that they, if the pain is bad, they'll do an injection in the sympathetic nerve,
That's great.
which I thought was really
That's an
interesting.
unfortunately common problem that I've heard when I was talking with Mike about it. So yeah,
Yeah,
that's great. That's
gets
good to know.
worse. It gets very angry. And so we tell patients, we're like, you gotta have grit through that one. But I want to ask, do you mind if I ask, Lorna, a lot of times we see, and I don't know, Dr. Salhanick, if you see this a lot, we see a lot of patients in a situation like hers, and I keep hearing the word clot over and over and over again, that it was a clot, especially when it comes to the upper, the aorta, the iliacs, and things like that. I'm curious about the mitigation of the clotting. And I always find that they keep putting a Band-Aid on the problem, but they might have AFib, they might have valvular issues in the heart, they might have an aortic aneurysm, whether it's thoracic or abdominal. And we've even had 2 patients where they were throwing clots down their legs, and unfortunately, they were in advanced stages of lung cancer and didn't know it. And so
Blue toe
I
syndrome.
always ask, where are these clots coming from? Number one, have we found a source? Is there a source? Is it something that we need to send you to a hematologist to find out if there's some hereditary, clotting disorder that is suddenly rearing its ugly head? And are we on the right cocktail, right? The blood thinning cocktail to mitigate these clots. So when I see these reoccurring, the revolving door of these procedures, I always say to ask, and in every single case, not sure if Lauren is, that's why I'm asking, every single case that has come our way, lo and behold, there's no anticoagulation therapy. They didn't do any checking to see where the clots were coming from, and they were coming from somewhere.
Yeah, I am on blood thinners, as well as aspirin. I have had, because of the ascites last year, they sent me for a whole battery of tests. So I've had an echo and the whole bit, a number of ultrasounds done. Everything's good with the heart, because that was my biggest fear, because there's heart issues in the family. So yeah, it's just now, when everything started, not this past January, but the one before, all along the doctors had been saying it was my sciatica, bursitis and sciatica in both sides. So that put it off for probably, I don't know, 6 months. Nothing was getting better. Then I woke up one morning and my baby toe on my left foot was all red and swollen and extremely painful. Which ended up, I guess, being either a piece of plaque or a blood clot or something, the surgeon told me, that had gone down and blocked the vein at the toe. It turned gangrene. I thought I was going to lose my baby toe. Anyway, it rectified itself after I had the stents done. So now, they originally wanted to do a bypass on both sides. I was in the hospital January 3rd. I am a caretaker for my husband who's had a stroke. So I couldn't just kind of stay in the hospital. I had to make arrangements. But I ended up back in the hospital January 5th, because my feet were turning purple at that point. So then the surgeon on call emerged that night, did the stents, one, two, I guess 6 stents down each side instead of the bypass. Now, they're all a vascular team at the hospital, so they're all in consultation with each other. So I don't know how one went from doing the bypass down both sides from the aorta down to the femoral to doing the stents, but
And, I think that just for everyone in the chat, and I should really make sure that I'm saying this, I need to give the benefit of the doubt to the doctors that were there treating you. I mean, I don't know all of the medical details about what it was, as you guys have been able to surmise just from our conversation. You can talk to some people and they'll be like, well, you just need to put some stents in there. And, it's like, that's way oversimplifying things. This is a very complex disease process with lots of options. And so there's a lot of decision making that goes into this. And, actually highlighting Mike again, you want to be thoughtful. You want to be thoughtful about what you do. And I want to give them the benefit of the doubt that they were being thoughtful about why they chose to do that. So I don't know all the details about it. One thing that could have been going on is that you could have what's called a blue toe syndrome, where there's a piece of plaque that has developed this chronic, we call it thrombus because we don't have another word for it. So this is coming back to what Kim was saying. Where's this clot coming from? Well, it's not really clot. It's like an amalgamation of different types of cell lines and other types of cells that glom onto each other and then break off when they become too heavy and they go down to the toes. I actually had a patient with this about 2 weeks ago at another hospital that we're currently working up because it's P.A.D. awareness. This is a P.A.D. problem that people don't always know about. I mean, even the other doctors, they didn't know about blue toe syndrome. They called me because they're like, we don't know why this guy's toes turn this color. He's got palpable pulses. And I was like, it's blue toe syndrome. Sure enough, it was. The point is that, so, coming back to why did that stent fail? You have small arteries, so they say. I mean, I need to give the doctors the benefit of the doubt, but sometimes, again, doctors will kind of blame patients for their disease process. But small arteries are a problem. The patient that I took care of a few months ago that I was looking at doing iliac stenting, like what you had undergone, and that patient's iliac artery is the size of some patients' tibial arteries. So the main artery that goes to their leg is the size of some people's arteries in their calf, to give you an understanding of what is a small artery. And I stopped everything I was doing, pulled everything out, we held pressure, and I went and talked to the patient's daughter, and then I ended up talking with the patient when they recovered. And I said, you've got back issues, take care of those. If you're still having problems, we're going to need to do this with open surgery because your arteries are too small to really accommodate this stent. What does a stent really do? It's not like it magically makes the stuff disappear. It just squishes it out into toothpaste and moves it in other places. If you've got really legitimate, very calcified plaque that's not really going to move, you can shockwave as much as you want. You can do all this kind of stuff. We don't have a technology that really makes that go away, short of removing that or bypassing it. And so if you have small arteries and you put stents in, you may not get what we would call luminal gain, increase in the size. Give you an example. If you've got a 5 millimeter artery and you put a stent that should expand 5 millimeters, but because of all the other stuff, it only goes 3 millimeters, that's still way too small and it's not going to work. So coming back to Kim's question, we call this stuff clot, but it may be, in my experience, it's really not been clot. All the stents that I've had that go down that get clot in them, it's not because there was a clot that got thrown. It's because there's new disease process, or the stent is failing because there's this stuff called neointimal hyperplasia that Heinz had brought up. That's why we try and give the Plavix to prevent that. But it's usually a mechanical problem. And at the end of the day, this is really, really important. It does not matter how thin your blood is. If blood does not flow, it is going to clot, because if blood is static, it will eventually just glom together because it just has to. So a lot of times, really and truly, what this probably is some type of issue with the stent. The stent was having problems and you were having issues with that, and people were maybe passing it off as sciatica. And really what they should have been doing is looking more thoroughly at the stent to try and fix that early. Everybody that we get stents on, I enroll them in our surveillance program so that we make sure we see problems before they come and have these issues, and we can be on top of them.
Wow, that's so. I'm so glad, Lorna. Thank you for being such a with your courage and being a great case study that, you know, for this, because I think we've learned a lot through this entire conversation.
And
And it really sounds like, I mean, compared to a lot of cases that we see across Canada, it sounds like your team is really thinking about this. They're really trying to work with
yeah,
you here. And so I don't know where you are there. You know, there are still opportunities if you do want a second opinion, just in case. You know, for example, Sunnybrook in Toronto has a full-fledged limb salvage program there that's renowned, you know, across the nation. So, and they just had a major conference there just in the past week. And so they might, you know, different doctors might have attended, your doctors might have attended, and they might have some different learnings. So it might be good to get back and just have another conversation if things are still bothering you, and maybe take some of what you learned from here and bring it there and have a, you know, another conversation with them. But we appreciate you. Let us know what happens. And if you have more questions, would love to talk to you again and have you back. But you mentioned, Dr. Salhanick, you know, when it comes to aortobifemoral bypasses, this is a question. We have a couple questions that have come in about that. We have a lot of doctors across the globe that are still using this as frontline treatment. And the more advanced vascular surgeons are always telling us that, you know, unless there's an infection, unless there's, you know, they can tell that there's this really big calcium trail, they should always go in and at least try endovascular first, at least go in with IVUS intravascular ultrasound and take a look to see, you know, what the landscape looks like once you go in. Um, so I'm just curious your thoughts on the actual indications for an aortobifemoral bypass, and at what point a patient can say, hey, doctor, you know what, I want a second opinion, number one. And then number two is, why don't we try an endovascular to see if it's just clot? You can slip a wire right through, no big deal, versus rock hard calcium, and it's just not safe.
ooh, Kim gonna get me in trouble. This is
I know.
another
So
them's fighting
you
words type
you can walk the
scenario.
line. You know, it's
And
just that we've
it's
had several patients that
yeah,
have been up for not only an aortobifemoral bypass, but axillary bifemoral bypasses. And the doctor says to us, because we'll advocate for them, we just ask the questions. You know, we're not doctors. We don't want to be doctors. It's not our role. It's not our lane. Our lane is to say, hey, let's just ask the questions, and the patient, the doctor can make their own decisions, right? And we've found in several cases that even a TPA and thrombectomy has prevented having a major surgery for some of these patients. Now, the reason they'll give, and they'll say to the patient every time, which is fair, well, you know what, it's not going to last as long as, let's say, an aortobifemoral bypass. I mean, those things, we've had patients, holy cow, you mitigate those risk factors. We have a patient at 30 years following an aortobifemoral bypass.
yeah,
So that could be really durable.
absolutely.
Mhm. But
So
an axillary is like 7 years,
yeah,
maybe 30% mortality rate.
oh, 7 years. I would give it like 8 months, maybe. Um,
See,
yeah. So the first thing I have to tell you again, as we had already kind of discussed, extra anatomic versus anatomic bypass. An aorta bifem is reconstructing your normal anatomy. So that's probably why it is a Cadillac bypass. And I tell patients that frequently when they need it. I have only had to do one AX bifem, and actually that patient ended up not needing it, oddly enough. It has to do with that they had an aortic dissection, and it's fascinating physics, but the long short is that they're fine. But that failed miserably. It's the only one I've done. I hope I never have to do another one. I think there is a very, 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 very limited indication for doing an axe bifem. It is not durable. The physics of it is not good. And then also they are no longer able to lift their arm up above this. You have permanently winged them, because if they do this, you can get this thing called liftoff syndrome, where it's, I don't know why they call it that. Basically, I guess because ripping it off the artery sounds bad, but that's exactly what happens. So yeah, axe bifems are not good unless there's a really strong reason why. You've touched on also kind of that concept again of acute versus chronic. I see no reason to go and do any of that for acute critical ischemia. that is something that we should be able to take care of now with great, devices like Penumbra, even some of the Inari stuff that's come out. We don't have to just sit there and drip with lytics and use technology from last century, which is the angiojet. I mean, sorry, my Boston friends, but it is old technology. We have saved many, many, many limbs doing those kinds of things. Chronic critical limb ischemia, I do think that then you get into, and this is where I was saying you're getting in trouble, or you get me in trouble, is that there are doctors that are good at endovascular surgery, and there are doctors that are not good at that. And there are doctors that are good at open surgery, and there are doctors that are not good at that. And sometimes you find someone that can do both. Sometimes you find someone that really is just good at doing the one or the other. And I think what you have to do is balance the results that you can get from that doctor. And I think that it's always worth getting a second opinion about anything, especially if you're going to do an aorta bifem, because there is a mortality associated with that. I can think of 2 patients, not of my own, that are other doctors that had claudication and are no longer here because of their complications from aorta bifem surgery. It is big time surgery. It is dangerous. So, you going and asking for a second opinion is not you not trusting in someone. It's you saying, I'm not willing to stake my life on that. Maybe there's some other options that are less invasive. So I think that that's a good kind of quiver or arrow to have in your quiver. Coming back to, should you do endo first? Lots of different opinions on this. There's zero data on any of that, because really and truly, it's about who can do this with good endovascular techniques. You can get anybody to go. So I'm going to be a little bit technical, and then I'll try and walk it back to explain what I'm talking about. But Kim, I think you probably understand this a little bit better. So you can get anybody that can go subintimal, go right up to the aorta where it's open, punch through, put some stents in, and say, we did it. You're all better. The durability of that is poor. Those stents are going to last for a couple months, maybe, and then they're going to be out, and then be like, well, you got to do the AFB. I do not do that. I've not had to use a reentry device for the last 5 years now, and I'm very proud of that. But that said, I mean, I might spend an hour and a half trying to recan someone's iliac. What I look at with endovascular success is, what is the quality of the lesion? If it is just chock full of calcium and it doesn't matter what you do, you're just not going to be able to push that, break that, do anything, get it out of the way. Open surgery is still the best answer that we have for super calcified, really tough lesions. If it has no outflow or very poor outflow, you're going to have to make outflow. Endovascular surgery fails if you do not have good outflow. So that is something that you're really going to need to probably just do open. That's the benefit of the AFB, is that you get great inflow because you're coming right off the aorta, and you build your outflow, because a lot of times most patients will have disease in their femorals, and as a normal part of the operation, most vascular surgeons, unfortunately, not all of them do this, and I have to come back and do it again, but most vascular surgeons will do a femoral and arterectomy at the same time. And that is probably the secret sauce as to why those are so effective. That plus the lifestyle modification. So to answer this question, that question pretty succinctly, it depends on your doctor. If your doctor is having good results with endovascular, and the questions that you ask them is, how many times do you have to go back and reopen those? How long are you monitoring these patients? And it's not just like, oh, I have a patient that, they come and see me once a year. It's like, no, we have a program. We monitor these patients. We have a number of patients that have been followed this many years, and this is the success that we have. That is a patient, that is a person that probably can do what you need to do endo. But if you don't have that, and they're sitting there telling you, I think an AFB is better in my hands, I think they're being honest with you and going to give you the best operation that they can offer. Doesn't mean that you have to go with them, but don't necessarily push someone to do a type of operation that they're not going to feel comfortable with, because they're not going to give you the best that they can.
Can you do me a favor? That was brilliant. Can you just explain outflow? I'd love to use this as a separate, because I use this all the time. I explain it to patients but I want it to come from a doctor, because I think that is the number one thing that we see over and over and over again, is especially, I never have a problem with bypasses at all. I mean, I think that there's still it's no matter what, it's always the hands of the doctor, right? And what they're most comfortable with.
Yeah.
But I still see this way too often, that they don't check the outflow. And we even have a cardiothoracic surgeon that tells it, he's like, before I do any bypass, I actually will go in, if it's a fem pop or fem tip, I will go in pedal. I'll go in with a wire and balloon through the foot and actually check. I don't trust anything. I won't trust the scans. I want to see for myself that there's a place for it to go.
Yep.
And we also see the aortobifems, like those, for the most part, if we don't have any infection, we had one with a serious infection, had to be replaced. And we're seeing that more and more, which is also, I think, where you're going with it. There's a lot of infections right now in hospitals, and if you can delay a procedure, avoid a procedure, walk, stop smoking, do your, diabetes control, always, the best frontline treatment, right?
See your
But
cardiologist and get your heart stent. I just had that with a patient a few weeks ago.
go to the cardiologist.
Yes. Don't worry.
And
one will be provided to you if you're in our practice, if you do not have one.
that is also in a good 3 in 5 people who suffer a heart attack have PAD. And we still see that surgeons, people that are checking the legs, vascular specialists, are not, putting the patient through heart stuff as well. You've got to get your heart checked. I can't tell you how many patients literally they'll get their legs fixed and then they're gone because they're now walking and their heart couldn't keep up with their legs. But outflow, go ahead and explain outflow, the importance of it, why it matters.
Imagine that you're on the highway and you get into an accident, and then you are able to get off early. You're like, oh, those poor bastards sitting down there, they have no idea. They're just gonna be sitting there, it's parked. And you come down and you get to a part of the highway that's open, only to find there's another accident. And then what ends up happening is the people behind you keep coming and keep coming and keep coming. And before you know it, everything's just backed up. This is the idea that we were talking about of, if blood's not moving, if the flow of traffic is not going, it does not matter how anticoagulated you are. You will not, think about it in terms of like car wrecks, like if there's a wreck there, everyone's going to stop and slow down. You're not going to just keep piling on, but it's still not moving, and functionally it's out. So that's the idea, is that you have to have something open downstream for the blood to flow. And if you don't have anything downstream that's open, it's just going to get piled up again in your brand new bypass. Another way to think about it is that, okay, because Kim, you probably heard about microvascular disease or small vessel disease. This is another problem that we fight, and that's why we've started using bone marrow aspirate concentrate to try and help build that up. But imagine that you're on the highway and there are no exits. It's great. You're just flying down. But I mean, I live in Dallas. Imagine you're driving up 75 and then it's just like, I don't see any exits. And by the time you know it, you're in Oklahoma and you're like, there is no way off this highway. So it doesn't matter how open that highway is. If there's no exits off of it to the tissue surrounding it, it's functionally not useful for you. And eventually you'll get to a stopping point where it's just like the highway runs out of road and you just start building up and piling up from there.
That was fantastic. And so is there a question that the patients, I think it's the most important question to be asking a doctor before they do any procedure, right? That is something that they should ask. They should ask about outflow. So when you phrase it for them, depending on whether it's, endovascular, above knee, below knee, or whether it's a major bypass, whether it's aorta or whether it's thumb pop, untip.
So honestly, I think using the term outflow is probably the best, because the doctor should know immediately what that means. If they don't, and I would say I would be very surprised, that might just be a litmus test about kind of the quality of the doctor that you're working with, because every doctor, every vascular specialist, and we're talking about cardiologists, we're talking about interventional radiologists, we're talking about vascular surgeons, general surgeons that do this, cardiac surgeons that do these things. everybody understands this concept of outflow. And if you bring it up and say, what does my outflow look like? Or are you concerned about my outflow? Or how do you deal with my outflow? And they don't have an answer for that, that might be a situation where you might be looking to talk to somebody else, because that is something that everybody has to have an answer to, because it's just so fundamental to how this all works. And again, it's physics. I mean, if you don't have somewhere to go, doesn't matter what you're bringing down to it, it's just not going to go anywhere.
It's been incredible. I feel so bad taking your time. We might have to just do this again, because this has been one of the most powerful conversations I think we had. I think this has been the most detailed, like really comprehensive. And we thank, Heinz and Lorna and Allison and for everyone bringing the questions. We still have so many more questions that have come in, which is amazing. But I just will definitely bring you back if you don't mind.
Yeah, I would love
but I'd
to.
love
This is a great
to.
opportunity. Thank you.
Yeah, no, this is fun. And I think it's kind of taking this in a whole new direction in terms of bringing in the case studies and being able to have a more comprehensive conversation. And especially having Lorna that knows so much about her situation and is incredibly eloquent. And I give Lorna so many props for being so engaged in her care and for taking the time to go in depth with her doctor and really try to understand everything. I think that is absolutely incredible. And I think everyone should. And that's why conversations like these with you help a patient to do this, help a patient to have a more productive conversation with their doctors. So actually, Mike has a question. So do collaterals create outflow,
Yes,
meaning the exits off the highway? Because
absolutely.
Mike, can we have a little celebration here again? Mike, Mark, you're going to love this. Sorry, we have to share this again, Mike. Mike and his incredible feat this week. 6 months ago, he could barely go a few hundred feet without claudication, severe claudication, was depressed. And Mike, what did you just do in the past week?
I've walked 13 kilometers over the Confederation Bridge from New Brunswick to PEI for the Terry Fox run.
There you go.
And I'm currently en route from New Brunswick to Toronto to pick my friend up from the UK, and we're going to go and do Niagara Falls on Tuesday. So we'll be getting all our steps in, walking around there as well.
Yes.
So tell him why you're wondering about those collaterals.
Tell me. There you go, man.
Because I've just been for an ABI the day before yesterday, a follow-up. My initial one was in January. And I've been to go and see my podiatrist a couple of days ago, and she repeated the ABI, and my right leg has gone from 1.0 to 1.03, which wasn't a concern. My right leg wasn't a concern anyway, but my left leg initially, sorry, my left leg was initially 0.68, and it's gone up to 1.05.
Yes.
Congratulations. I mean, I've not stopped walking, and I mean, I've just started line dancing. I've started running on the treadmill now. I've quit smoking, changed my whole diet, changed my whole life really because of this diagnosis. So yeah, pleased with it this week.
That's fantastic work, man. I mean, that's the hard work. And I mean, like, for everybody on the chat, just to emphasize, I mean, like, that is the hard work. And I'm sure, Mike, tell us about, when you first started, what were you thinking? Kind of what was going through your head? You're like, oh, I gotta do this, or?
Yeah, well, when I was first diagnosed, my mum's actually a P.A.D. patient as well. My mum's a below-knee amputee because of it. She had a failed bypass. So unfortunately, yes, I did carry on smoking throughout my life, and my mum's amputee was 12 years ago. As soon as I found out, I went into complete depression for a good 6 to 8 weeks. I didn't want to move off the couch. I was so down. I started Googling things, and even though I knew quite a lot, not quite a lot, I knew some facts about PAD anyway. Google just completely sent me into a hole, completely sent me into a depression hole. And then I just thought to myself, you know what, I need to do something to to defeat this or make it better for myself and make it tolerable. I was struggling to even walk up the hill outside the house. I was getting cramp in my left calf, really, really bad. I had to stop a couple of times. Now I can walk up that same hill. We live at the top of the hill, and I can walk up that without no pain now. I can, because of what I've been doing over the last 6 months has been, I mean, I do. Um, so yeah, I've done this and I've made this. I'm proud of myself, and I know how much Kim's proud of me. I know how much the guys are proud of me off the group, and I can't thank them enough. It's the support has been amazing.
That's beautiful.
But yeah, I've done it.
Great work, man. Great work. You did that is all you. I mean, like just amazing work. Congratulations. I'm very proud of you as well. I know that we're just getting to meet now, but like I said, I know the work that goes into that, and I mean that is the daily commitment to that. And that's the hard part of it, is that as you experienced, I mean, there's so many options.
Yeah, I mean, I know that I've still. Yeah, I know that I've still got the narrowing because I've not got a full blockage. It was 75% narrowed in my superficial femoral.
But you beat it. I'm telling you right now, you beat it. You know?
Isn't that incredible?
It is. As
so the collaterals, so collaterals create outflow.
Yep. Absolutely.
Mike's giving a thumbs up.
Fantastic.
And it's so interesting because that was one of the things that you and I, Dr. Salhanick, were kind of messaging about, that we're big proponents about. There's so much you can do with PAD. Take the bull by the horns and actually just get out there and do it. And I know you're a big proponent. It's something, give us your best motivational speech, Dr. Salhanick, for walking as medicine. You can give analogies, you can anything, take it wherever you want. But I want, we're patients, everyone out here, patients, motivate us to walk.
Oh my goodness. So I am, as I tell my patients all the time, I mean, you know, this is your life. We're here to support you, and you know, we're going to do everything that we can to make sure that you leave this world with everything you came in with. And this is the key. You putting in that work every day to get up and just make a little bit of progress. 10 minutes a day, and then before you know it, that's going to be 15 minutes a day, and then 20 minutes a day, and before you know it, you're going to be like Mike, and that pain is going to go away, and you're going to have done that without any of these doctors going and doing any of these fancy techniques, and it is all your hard work and effort that is and can pay off. And I mean, thank you so much, Mike, for sharing your story with us, because you are a shining example of how this can be effective. You didn't need to have any surgery for it, didn't need to have any procedures for it. You were able to get it all done. Good work.
Yeah, thank you. Thank you, Matt.
And just the final question for this one, I just think this is, patients love this. It is not to mock patients or anything. It's because patients really want to know, you know, the different experiences. And, you know, sometimes you kind of do have to shake your head. You know, I can't believe a patient did this or said this. And it's a good lesson for everybody, because someone will resonate, and we all make mistakes. It just is what it is. We've had Dr. David Armstrong share about, you know, a patient with diabetic neuropathy couldn't feel his toes, and a dog ate a couple toes. They went to the veterinarian first to get the toes, and then went to the doctor. The veterinarian was like, I think you need to go to the doctor. But good people, because they love their furry friends. But we've had people that have stapled up their socks, bless their heart, trying to keep their socks up, not realizing like it happens. We had a patient that used an enema in the wrong cavity and triggered AFib, um, you know, causing a little trauma to the body. So we've had a little bit of everything. Oh, and yesterday, our podiatrist of the year, Sarah Rose from Mass General over in Boston, Massachusetts, shared that one of her patients that they let the toe auto amputate, she wanted to save it. So she was looking for someone who specializes in embalming, and she wanted to wear it as a necklace, around her neck. So we hear it all, but I would love to hear any experience. Oh, but then you have the more serious side. You know, a lot of the doctors, you shake your head because patients will come in with a bag, big black garbage bag around their leg with a rubber band, and you're like, what the heck? Why did you wait this long? You're septic. It's wet gangrene. Clear up your leg. Why in the world did you wait this long?
Yeah.
And so and that happens. And these are great lessons, for people to learn from.
Oh goodness.
Tough. I stumped you on that one.
You
Just
did.
wait till I ask you about your mediocre superpower you wish you had.
Oh man. I'll have to. That's the brains could be spinning on that one. One of my favorite stories. So patients ask all the time about like, what do I do for recovery? When can I do this? When can I do that? And the honest truth is that there's nothing that's like really set in stone. Everyone's body's a little bit different in how they heal. And so I always want to give patients general guidelines rather than be like this, 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 and this, because patients can kind of take those and be like, well, the doctor said I can't drive, or the doctor said I'm good to drive. And the family member's like, you are not good to drive. You should not be doing this yet. And so when it comes to like wound care, I generally tell patients like, yeah, you don't have to do anything special to it. Just for incisions that I make, just let some warm soapy water run over it. Just be gentle to it. And I had one patient call me telling me that they couldn't get the red off of it. And so they started scrubbing it with their toothbrush to get the red off it. The patient had staples. And so as a normal part of staples, the reason why I put staples in patients is because I know that they're going to get swelling afterwards. And the staples really do a good job of holding firm and keeping the wound together so it can fully heal, even despite the swelling. So it was red because the skin was pulling on the staples. And so I now have to tell patients to not scrub their incisions with a toothbrush as a result of this. And then the patients always look at me and they're like, what? And I'm just like, yeah, this is really more the idea of if you don't think this is a great idea to do it, don't do it. So trying to give them that kind of practical experience. I could come up with some really just awful ones from training, but I don't think that that's going to be, this is not polite company to do that in. But I think probably the worst one that I've had in the last couple of years was a patient that did come in with maggots. But the way I found out was a little bit more surprising. So this patient came in, I thought their bypass was occluded. I was at another hospital and I had given instructions to the cath lab to get that patient ready for angiogram. Took them in for an angiogram. Did the whole angiogram. It actually looked fantastic. Everything was open. It looked really good. I was like, I don't know why this guy's having problems. And the doctor had called me kind of freaking out. They're just like, the wound looks terrible. I was like, weird. So we're finishing up. I've closed up. They're about to take the drapes off. And I kind of look underneath and I start to see that the wound is moving. And my initial thought was, I was like, oh no, because this bypass is a distal AT bypass. It's very superficial. So you can kind of see it pulsating underneath. And I was like, oh no, I've done something. And now there's like a pseudoaneurysm or something like that. And he's about to blow out because there's a bad infection, because that's what the doctors were thinking. The wound had broken down and there's bad infection. And then I kind of looked a little closer and I pulled back the curtain. And I started to see all the reasons why I was pulsing, because of the maggots that were in it. And I was like, this is also not good. So he stayed the night for a couple nights while we cleaned that up. His story, and Kim, this is something that maybe we'll talk about offline, but Calciphylaxis was his story.
Oh, yeah.
So he actually had really bad calciphylaxis. We treated him with a couple doses of sodium thiosulfate, and his wounds healed remarkably. I got some pictures for it. It's bizarre, and no one talks about it. And then the other thing is HIT, so heparin-induced thrombocytopenia. It's a big problem that goes unrecognized a lot of times. But that was definitely one where I was like, yeah, that stays with you.
Yeah, oh my gosh, that definitely does. That was a good one. So I just have to, your mediocre superpower, just for fun. Just because I threw it out there, because it's my new question du jour, because I used to work at a place called Pando Daily, and there was a young woman on there that came up with this question somehow, and we would ask every entrepreneur it, and we would get the most bizarre answers, and it's what is your if you could have any mediocre superpower, what would it be? It can't be a super cool one. It has to be a not so cool one, but it's based on something that just annoys you every single day. So I can give you a couple examples. Like, a couple of the entrepreneurs said they'd like to be not to be cold when they get out of the shower, or one of them said he'd like to be able to remove his arm when he's spooning with his wife, because his arm always goes to sleep and he always likes to have his wife close, but that's a complication of that problem. We had a doctor that just the other day shared with us, well, I just wish I had this telepathy with my team, because every single morning on my way in, the operating room will call me and ask me, well, which way do you want to position the patient? He just wishes that there was this telepathic thing. He appreciates them calling, but man, every day on the dot, it's like that same call that he feels like, I wish there was telepathy for that. So just thought if there's a fun one that you might have to share, patients might get a kick out of it.
Being a little bit of a jerk, I might tell that guy, well, text messages work really well too.
It's true.
But my mediocre superpower, this isn't something that annoys me. This is, I wish that I could end a patient encounter like on time, politely. And that it was just so easy to do. Like I could, bam, it's just like you said, it's like a superpower. Because I do tend to run behind in clinic, and as you probably have guessed, it's because I like to talk with patients and spend time. And I mean, I think it's important. I think patients, they come to the doctor because they want to feel cared for. I mean, they want to be fixed, but I also think that it's an important aspect of it that your patients feel that you really care for them, because we do. I mean, like at our practice, our motto is to treat patients like you would want your family members to be treated. But sometimes that means that we're running a little late. And so it'd be nice, it would be a great superpower that I could have, where I could like have them feel that caring aspect, and then also be like, and it's been time. We need to move on to the next patient.
That's so sweet. Well, thank you so much, Dr. Salhanick. You have been more than generous with your time. We really appreciate you. We are going to do this again. Remember those two topics. We have to get to those sooner rather than later. So would like to probably go ahead and start the process in scheduling for maybe October or November, and
Yeah,
get something in the books, for
That's
this.
great.
But Dr. Salhanick, we really appreciate you. Everyone's sending in, thanks for you. In Dallas, Texas. Thank you so much for joining us. Make sure, if you want to continue to have great conversations like this, go ahead and like this video, subscribe to our channel, and click that little notification button to get notified when we have great doctors such as Dr. Salhanick joining us to answer your questions and so much more. But just remember, this is for educational, informational purposes only. Always check with your own doctor and your own healthcare team for explicit consent before acting on any advice or information happening here that we provide here, because we don't know your medical situation. We are not your doctor. But thanks everyone for joining us. Have a great rest of your weekend.
Thank you.